Welcome to the Deep Dive, the show that acts as your personal expert guide through the most complex, source-heavy fields of medicine. Today, our mission is to cut through the vast and often overwhelming complexity of clinical immunology. We are diving deep into the core mechanisms, drawing out the absolute must-know conceptual anchors and, the critical clinical links from Davidson's medicine. And we're focusing this specifically on what you, the first or second year medical learner, need to truly master this subject, not just memorize it.
This is a crucial deep dive. The immune system is arguably the most sophisticated physiological network in the body. I mean, it faces this immense existential challenge every single second. How do you identify and destroy every imaginable pathogenic threat, bacteria, viruses, fungi, parasites, while at the same time ensuring absolutely zero collateral damage to the host itself? When that balance fails, whether it's through deficiency or dysregulation, the clinical pathology can and does touch every single organ system. We really need conceptual clarity and structure above all else here.
Absolutely. So let's establish our foundational conceptual framework right now. Imagine the body as a heavily defended, multi-layered medieval fortress. Your immune system is the specialized defense force for that fortress. And we can organize it into two major interconnected layers. First, the innate system. This is your immediate rapid response team. Think of them as the walls, the moat, the security guards, and the local police force. They are nonspecific, meaning they don't really care which specific bacteria breached the gate, only that something breached it and they react within minutes.
Right. And then you have the adaptive system. These are your special forces, the intelligence network. They take time to mobilize, sometimes days. But their power comes from two key factors. They are exquisitely specific, able to identify a single molecular signature, and critically, they possess long-term memory. They learn from every single fight, ensuring that the second encounter is rapid and just overwhelming. So we have to start with that immediate, non-specific response.
Okay, starting at the very perimeter of our fortress then, we find the physical barriers. These are your first line of defense, the structural elements that make breaching the wall difficult in the first place.
The primary physical barrier is, of course, the skin. And it's not just the structure of the tightly packed keratinized cells that matters, though that provides a tough mechanical shield. It's the incredibly hostile chemical environment it maintains. We're talking about low pH, the acid mantle, low oxygen tension, and the constant secretion of lysozyme, that remarkable enzyme that specifically targets and hydrolyzes the peptidoglycan cell walls of bacteria. On top of that, the skin produces antimicrobial peptides called defensins, which are basically broad-spectrum antibiotics.
And if a pathogen does manage to bypass the skin, it then encounters the internal epithelial surfaces, so the mucous membranes of the respiratory, GI, and genitourinary tracts. And these tracts rely really heavily on secretions. Mucus traps the invaders, and then you have these mechanical systems like the rhythmic beating of cilia in the respiratory tract, constantly sweeping that mucus and trapped debris up and out.
And in the stomach, we rely on harsh chemistry, hydrochloric acid, and constant movement, peristalsis in the small bowel, to either kill or just move pathogens along. A crucial component here, and one that really links the innate and adaptive systems, is immunoglobulin A, or IgA. Now, while IgA is an adaptive antibody, it is secreted across these mucosal surfaces to act as a barrier. It stops bacteria and viruses from attaching to the underlying epithelial cells in the first place.
So it's like a non-stick coating on the wall.
Exactly.
Yeah.
A perfect analogy.
Okay, let's deepen this concept of the moat a bit. We have about 10 to the 14 commensal bacteria living in symbiosis at these surfaces. This is the microbiome. And it provides an incredibly effective constitutive defense. I mean, these resident bacteria are fighting a constant silent war, competing fiercely with any invaders for space, for nutrients, for resources.
And they don't just compete, they actively defend. They produce substances like growth-inhibiting short-chain fatty acids. And importantly, the presence of this commensal flora also helps to shape our immune system, influencing the development of crucial cells like regulatory T cells, which helps maintain intestinal tolerance.
And the major clinical takeaway here, the anchor for this section, is what happens when this delicate ecological balance is just obliterated. When you use broad-spectrum antibiotics and wipe out that protective commensal community, the niche is left wide open. And the classic catastrophic consequence is the rapid colonization and opportunistic infection by Clostridioides difficile, which can lead to severe pseudomembranous colitis.
A disaster. The body trades one problem for a much, much worse one.
So once a pathogen breaches the wall, the immediate internal responders are activated, the phagocytes, the professional eating cells like neutrophils, monocytes, and tissue-resident macrophages.
And these are absolutely essential for clearing bacterial and fungal threats.
But how do they know what to eat? I mean, they can't wait around for the adaptive system's detailed ID cards.
No, they use pattern recognition. Phagocytes express pattern recognition receptors, or PRRs, like toll-like receptors and NOD-like receptors, on their surfaces and internally.
And these PRRs are designed to recognize, what, generic molecular structures?
Exactly. Highly conserved molecular structures that are unique to non-mammalian life. These are the pathogen-associated molecular patterns, or PAMPs. Think of PAMPs as generic security tags worn by the enemy. Bacterial DNA, viral double-stranded RNA, flagellin or lipopolysaccharide LPS from gram-negative bacteria. Recognizing these generic tags is really the foundational step of the innate alarm system.
So when a PRR interacts with a PMP, it sets off major internal communication cascades. Let's focus on two of the most critical ones. First, the binding activates nuclear factor kappa B, or NFA-B, and this is a master switch for the inflammatory response, right?
It is. To explain that mechanism in a bit more detail, in a resting cell, NFA-B is held inactive in the cytoplasm by an inhibitory protein called IB. When that PRR alarm goes off, the signaling cascade triggers the destruction, the degradation, of IB. Once IB is gone, NFA-B is then free to enter the nucleus and activate the transcription of hundreds of genes, most notably those coding for pro-inflammatory cytokines like TNF-alpha and IL-6.
Okay, and the second critical alarm?
The inflammasome, often formed around NLR proteins like NLRP3. This is a huge multi-protein complex formed in response to PMPs or even damage-associated molecular patterns, which are released by our own injured host cells. The final action of the inflammasome is the activation and massive secretion of IL-1.
And IL-1 is an incredibly potent inflammatory mediator.
Knowing its role is clinically very high yield because it's a key pathogenic driver in crystal-induced inflammation, like acute gout, and in the genetic periodic fever syndromes we'll discuss later. Blocking IL-1 is a highly effective targeted therapy in those diseases.
Now, pattern recognition initiates the process, but the actual engulfment phagocytosis is greatly enhanced by something called opsonization. So if the pathogen is slippery or hard to catch, opsonins are like molecular handles that make it an easy target.
Yes, they're molecular bridges that link the pathogen to the phagocyte's surface receptors. The primary opsonins you absolutely need to memorize are the acute phase protein C-reactive protein, CRP, the complement fragment C3b, and antibodies, specifically IgG, which are produced by the adaptive system. The sheer efficiency of opsonization shows you just how critical these soluble proteins are in optimizing the whole killing process.
Okay, let's zoom in on the primary foot soldier of this whole operation, the neutrophil. These are short-lived fighters, produce nonstop about 10 to the 11 cells every single day, but they are transient. Their half-life is roughly 6 hours.
They're the definition of rapid disposable infantry.
And their job requires getting them from the bloodstream to the site of injury fast.
And this process is tightly controlled by adhesion molecules and local signaling. Chemotactic agents, particularly interleukin-8 or IL-8, act like scent trails, guiding the neutrophils through the blood vessel wall and into the tissue. This relies on the precise upregulation of adhesion molecules on both the neutrophil and the endothelial lining, allowing them to roll, adhere firmly, and then migrate out.
Once they're into the tissue, they kill. And the most powerful killing mechanism occurs inside the phagosome and is called oxidative killing or the respiratory burst. This process consumes a massive amount of oxygen.
It does. The central enzyme here is NADPH oxidase. It uses oxygen to generate highly toxic reactive oxygen species, or ROS, starting with superoxide and hydrogen peroxide. Crucially, another enzyme, myeloperoxidase, then takes that hydrogen peroxide and chloride ions to generate hypochlorous acid.
Which is the active ingredient in household bleach.
It is the ultimate antimicrobial agent used inside the phagocyte.
But there's another fascinating, almost self-sacrificing method as well, isn't there? Netosis.
Yes, neutrophil extracellular traps. When it's faced with an overwhelming infection, the neutrophil can choose to die. But in doing so, it explodes its nucleus, ejecting this massive sticky web of decondensed chromatin intertwined with granule proteins like elastase.
And the purpose is just purely physical.
Purely physical. This chromatin net physically immobilizes or traps the microbes extracellularly. It prevents their spread and allows other phagocytes to potentially clean them up. And the accumulation of these dying and dead neutrophils, along with all the debris of the battle, That's what you see clinically as pus or an abscess.
So that white, creamy material is literally the grave of your neutrophils.
That's exactly what it is.
That sets the stage perfectly for communication via cytokines. These are the signaling proteins that allow the entire immune network from the brain to the bone marrow to coordinate a response.
The sheer number, over 100, and the overlapping functions of cytokines make them complex, but their underlying signaling pathways are fundamentally high yield for pharmacology. We already detailed NFO, the immediate alarm system responsible for that early pro-inflammatory gene transcription.
The second, and perhaps even more pervasive pathway, is JAK-STAT. That's Janus kinase signal transducers and activators of transcription. And this mechanism is used by dozens of receptors, including those for growth factors and essential immune cytokines like IL-2, IL-6, and IFN-gamma.
Mechanically, when the cytokine binds to its receptor, it causes the receptor chains to move closer together to dimerize. This dimerization activates associated intracellular proteins, the JAKs. The activated JAKs then phosphorylate the receptor itself, creating binding sites for STAT proteins. Once bound, the STAT proteins are also phosphorylated, they detach, they dimerize, and finally they translocate to the nucleus to induce gene transcription. It's an incredibly direct, fast signal from the membrane to the DNA.
And this mechanical understanding is absolutely key to modern therapeutics. We have monoclonal antibodies that target the extracellular cytokine itself, like the widely used TNF-alpha inhibitors. But we also have small molecule drugs, the JK inhibitors, like tafasitamab, which penetrate the cell and block the JK enzymes inside the cell, shutting down the downstream signaling regardless of which cytokine is trying to send a message.
Right. Now for the nuclear weapon of the innate system, the complement system, this is a biological cascade involving over 20 distinct, tightly regulated proteins, mostly produced by the liver. It's very analogous to the coagulation cascade in its capacity for rapid, devastating amplification.
And the system exists to achieve three goals: kill pathogens, enhance phagocytosis, and promote inflammation. But it can be activated in three distinct ways, all leading to the same endpoint.
The first and most immediate is the alternate pathway. This is a purely innate mechanism. It's triggered directly when the C3 protein binds to the foreign surfaces of bacterial cell walls, specifically structures like LPS from gram-negative bacteria, initiating the cascade without needing any antibodies.
The second is the classical pathway. This one requires the adaptive system's involvement. It's activated when multiple IgM or IgG antibodies bind to an antigen, forming an immune complex. This binding exposes a site on the antibody's Fc region that C1, the first complement protein, recognizes and binds to.
And the third is the lectin pathway. This is another antibody-independent route. It's triggered when mannose binding lectin recognizes and binds to specific microbial carbohydrates, like mannose, on the pathogen surface. MBL is structurally similar to C1 and directly activates the cascade further down the line, essentially skipping the need for an immune complex.
And regardless of the activation route, the eventual goal is the formation of the membrane attack complex, or MEC. It's composed of proteins C5 through C9, and the MEC assembles into a large pore or channel inserted directly into the pathogen's cell wall, causing catastrophic osmotic lysis.
The clinical anchor here is the MAC's necessity. It is the crucial defense against certain encapsulated bacteria, especially Neisseria meningitis and Neisseria gonorrhoeae. People who are deficient in the MAC components, C5, C9, suffer recurrent, severe Neisseria infections.
Since this system is so destructive, it must be held in incredibly tight check to prevent host damage. That's the role of control proteins.
Yes, we have soluble regulators like C1 inhibitor and factor H, but crucially, we have membrane-bound regulators on our own cells.
And here's a very high-yield clinical anchor for your board, CD59 and DF, or decay accelerating factor.
Right. These are proteins anchored to the surface of our host cells, and they specifically prevent the assembly of the terminal complement pathway, the MAC. A deficiency in the anchor structure that holds these proteins to the red blood cell surface results in a disease called paroxysmal nocturnal hemoglobinuria, or PNH. In PNH, the red cells are constantly under attack and lentillized by complement, leading to chronic anemia and the thrombotic events.
And the treatment for PNH perfectly illustrates the mechanism. Eculizumab. This is a monoclonal antibody that targets C5, effectively blocking the formation of the MAC and thus protecting the red blood cells. It shows how precisely we can target single points in this cascade.
Okay, moving to the other specialized innate cells. Mast cells and basophils are structurally similar. Both carry large granules containing preformed inflammatory mediators, most notably histamine. They are absolutely central to allergic disorders. Mast cells reside in tissues like the skin and mucosa, and they act as sentinels, primed for action by binding IgE antibodies, which we'll get to later.
Finally, the natural killer, or NK cells. These are large granular lymphocytes. They are part of the innate system because they are not antigen-specific and they do not possess memory. They patrol for two main types of cells, T cells and virus-infected cells.
And their mechanism of killing is unique and ingenious. Many viruses and tumors try to hide from the highly specific adaptive T cells by downregulating their surface expression of HLA class I molecules. NK cells recognize this specific absence. They are naturally inhibited by seeing normal HLA class I, sort of a don't shoot the civilian signal. When a cell downregulates HLA class I, the NK cell loses that inhibitory signal, is then activated by activating signals, and it proceeds to kill the target cell by releasing perforin and granzymes.
So they're crucial for catching the evasive criminals.
Exactly.
Okay, let's pause and anchor that innate knowledge. If the complement system is activated directly by a gram-negative bacterium via its lipopolysaccharide, which pathway is being utilized? And based on what we just discussed, why is the specific treatment for PNH eculizumab so effective? If you need a moment to lock that in, just rewind and listen again to the complement section.
The direct activation by LPS utilizes the alternate pathway. And eculizumab works because it blocks the central complement molecule C5, which is necessary for the final assembly of the membrane attack complex, the MAC. And that prevents the complement-mediated destruction of host red blood cells in PNH.
Perfect. Now, if the walls are breached and the innate security guards can't contain the threat, we call on the special forces the adaptive immune system. This system is defined by three fundamental high-yield hallmarks that distinguish it entirely from the innate response.
First, exquisite specificity. Adaptive cells can differentiate between incredibly minor variations in molecular structure, ensuring the response targets only the pathogen. Second, high adaptivity, meaning the system can generate receptors against an almost unlimited, theoretically infinite number of molecular shapes it has never encountered before.
And third, the real game changer, immunological memory. Once a fight is won, the Special Forces unit retains specific, long-lived cells, memory B and T cells, that ensure the next time they encounter that exact pathogen, the response is overwhelmingly faster, stronger, and more precise.
This complex force requires extensive organization provided by the lymphoid organs, the training camps, and deployment centers. The primary lymphoid organs are the sites of maturation and training, where the cells learn the crucial lesson of self versus non-self.
And these primary sites are the bone marrow, where B cells mature, and the thymus, where T cells mature and undergo these critical selection processes. The thymus is most active during childhood and gradually undergoes age-related involution after puberty, but its early work is foundational to the T cell repertoire.
Then you have the secondary lymphoid organs.
Yeah.
These are the meeting points, the deployment centers where antigen is concentrated and cells interact. The spleen is responsible for filtering antigens and pathogens from the blood, and it's a major site of antibody production. The lymph nodes are strategically positioned throughout the body, filtering interstitial fluid and trapping antigens draining from peripheral tissues.
To truly understand the adaptive response, you really need a strong mental anchor for the lymph node structure. Picture it in three functional zones. The cortex is the B cell zone, containing primary lymphoid follicles. If B cells encounter their antigen, these follicles rapidly swell into germinal centers, a high-intensity combat zone where B cells proliferate and mature.
Moving deeper, the paracortex is the T cell zone, densely packed with T lymphocytes and the critical dendritic cells, the master antigen-presenting cells. Finally, the medulla contains the blood sinuses and is the exit route, primarily housing the antibody-secreting plasma cells that have finished their differentiation. This precise arrangement ensures that APCs, T cells, and B cells can meet and coordinate their response efficiently.
Let's start with the first arm. Humoral immunity, mediated by B lymphocytes, which produce soluble antibodies. A B cell has a unique surface receptor, the B cell receptor, or BCR, which is essentially a membrane-bound antibody capable of binding to intact, often soluble, antigen.
Right. And while B cells can bind antigen directly, the full, powerful activation required to launch a protective response is typically a two-signal process, and it's highly dependent on T cell help. Signal 1 is the antigen binding to the BCR.
And signal 2 is the help from a specific CD4 plus T helper cell. This help involves physical interaction, specifically the T cell's CD40 ligand binding to the B cell's CD40 molecule, alongside the release of specific cytokines like IL-4 and IL-5. So this signal 2 is what commits the B cell to a vigorous, long-term response.
Upon activation, the B cell begins intense clonal expansion, generating thousands of identical copies of itself. This proliferation is paired with a phenomenal process called somatic hypermutation, where the genes coding for the antibody binding site are intentionally mutated. This is nature's evolutionary pressure cooker, resulting in the selection and survival of B cells whose receptors have significantly higher affinity for the antigen.
And these optimized B cells then differentiate into two primary populations: long-lived memory cells that lie in wait for the next exposure, and the short-lived but highly productive antibody factories, the plasma cells.
Which migrate to the bone marrow and medulla of a lymph node to just flood the body with specific antibodies.
And the antibodies themselves, or immunoglobulins, are structured as a Y shape.
Exactly. The two heavy and two light chains define its structure. The heavy chain defines the class IgG, A, M, E, D. Functionally, the twin tips of the Y are the Fab region, which determines specificity by binding the antigen. The base of the Y is the Fc region, and that dictates the biological consequence. Should it activate complement, be a handle for phagocytosis, or bind to mast cells?
And the ultimate anchor here is understanding the distinction between the primary and secondary antibody response, as it is the very definition of memory and the fundamental reason vaccines work.
Right. In the primary response, the first exposure, it takes a long time, about 5 to 10 days, to generate B cell clones, for somatic hypermutation to occur, and for antibody levels to peak. The antibody produced is low in quantity, low in affinity, and it's predominantly the large pentameric IgM. IgM is efficient at binding complement, but it's structurally bulky and short-lived.
The secondary response, on the other hand, so the second exposure maybe years later, is radically different. Thanks to the immediate activation of those memory B cells, the response is incredibly fast, peaking in just 2 to 3 days. It produces a vastly higher amount of antibody, and thanks to the prior hypermutation, this antibody is of extremely high affinity and is dominated by IgG.
Which is small, stable, and circulates systemically for long periods. IgG is the workhorse of long-term protection.
Now, we shift to cellular immunity, mediated by T lymphocytes. If B cells are primarily concerned with extracellular pathogens and toxins, T cells are the primary defense against intracellular threats: viruses, fungi, intracellular bacteria, and they hold the critical immunoregulatory function for the entire system.
The single most crucial rule for T cells, and you must remember this, is that they cannot see intact, soluble antigen. This is their absolute security clearance policy. To be activated, the protein must first be processed, broken down into short peptides by an antigen-presenting cell, or APC, the best of which is the dendritic cell, and then is presented on the APC surface complexed with the human leukocyte antigen, or HLA, molecule.
And T-cell activation is a complex security check that absolutely requires two distinct signals to prevent inappropriate activation, so autoimmunity.
That's right. Signal 1 is the T-cell receptor, the TCR, binding specifically to the peptide HLA complex. This confirms the T-cell has found its target antigen presented correctly. But this signal alone is not enough to activate the T-cell.
So it needs signal 2, the co-stimulatory signal. This usually involves the CD86 molecules on the APC binding to the CD28 receptor on the T cell. You can think of signal 1 as showing your ID, and signal 2 as the fingerprint scan and retinal confirmation.
That's a great way to put it. And if the T cell gets signal 1 but no signal 2, it assumes the antigen is being presented by a non-professional APC or under the wrong context, and the T cell becomes functionally hyperresponsive or anergic. This is a critical mechanism of peripheral tolerance, preventing T cells from attacking self-tissue.
And following signals 1 and 2, there's usually a signal 3, the production of IL-2 by the activated T cell itself. And IL-2 acts as an autocrine-positive feedback loop, driving explosive proliferation of the newly activated T cell.
Just as important are the inhibitory signals, the brakes on the system, which are crucial anchors for current therapeutics. Molecules like CTLA-4, which competes fiercely with CD28 for that CD86 binding, and the PD-1/PD-L1 pathway actively shut down T-cell responses once the threat is cleared. These pathways maintain self-tolerance and prevent chronic T-cell activity.
We classify T cells based on their surface markers and the type of HLA they recognize. CD8 plus T cells recognize peptides presented on HLA class I molecules. And since class I is expressed on virtually all nucleated cells, CD8 plus T cells can monitor every cell in the body. They are the cytotoxic T cells, and they kill infected cells directly by releasing perforin and granzyme, inducing apoptosis. They are the primary defense against viruses.
Then you have the CD4 plus T cells. They recognize peptides presented on HLA class II molecules. And class II is typically restricted to professional APCs, dendritic cells, macrophages, B cells. So CD4 plus cells are fundamentally helper and regulatory cells. They orchestrate the entire adaptive response through their command and control function via cytokine release.
And the CD4 plus T helper subset is highly differentiated based on the cytokines they produce. This differentiation determines the type of immune response that gets launched.
Right. You have Th1 cells, the cellular immunity specialists. They produce IL-2, IFN gamma, and TNF alpha, cholesterol for activating macrophages and coordinating defense against intracellular bacteria and viruses. Then Th2 cells, the humoral immunity specialists. They produce IL-4, IL-5, IL-10, IL-13. They promote B-cell differentiation, Ig production, and are central to allergic responses. Th17 cells, the mucosal defense specialists, they produce IL-17. They are highly pro-inflammatory, essential for recruiting neutrophils to the mucosa, and critical for defense against extracellular bacteria and fungi. And finally, Tregs, the peacekeepers. This specialized CD4 plus subset actively suppresses T-cell activation, crucial for preventing autoimmunity. They do this by producing anti-inflammatory cytokines like TGF-beta and IL-10.
Okay, let's cement these core T-cell concepts.
If a naive T cell successfully binds to a peptide HLA complex, that's signal 1, but fails to interact with its co-stimulatory molecules, signal 2, what crucial outcome, vital for maintaining self-tolerance, is likely to occur? And what HLA class is exclusively used by those specialized immunoregulatory CD4 plus T cells? Review the T cell activation and subsets if you need to solidify these concepts before proceeding.
The T cell would likely become functionally unresponsive, or anergic, which is a mechanism of peripheral tolerance. And all immunoregulatory CD4 plus T cells absolutely require HLA class II molecules for their activation and recognition.
Perfect. So now we're at the system in action and in overdrive. Inflammation. The immediate necessary consequence of immune activation is inflammation, the coordinated tissue response to injury or infection. It is absolutely essential for clearing debris, killing invaders, and enabling tissue repair.
Acute inflammation is rapid, protective, and involves a complex interplay of the innate system cells and soluble mediators. Every student has to recognize the classic cardinal signs: rubor, redness; Keller heat, dolor, pain; and tumor, swelling.
And these local signs are driven by vascular effects. Chemical mediators like histamine and prostaglandins cause powerful local vasodilatation, leading to redness and heat, and dramatically increased vascular permeability. That allows protein-rich fluid to leak out of the capillaries, causing swelling or edema. And this whole process facilitates the traffic of fluid and inflammatory cells, primarily neutrophils and macrophages, into the tissue.
But the body also mounts a systemic reaction. Pro-inflammatory cytokines, especially IL-1, TNF-alpha, and IL-6, leave the local site and circulate. They act on the hypothalamus, raising the body's thermostatic set point, causing fever, and crucially, they travel to the liver to trigger the acute phase response, or APR.
The APR is the rapid production of specialized proteins by the liver, and the gold standard APR protein is C-reactive protein, or CRP. Its levels can increase staggeringly 100 to 1,000-fold within just 6 hours of the inflammatory stimulus beginning.
And CRP is clinically valuable because it acts as an effective opsonin, enhancing phagocytosis, and it has a very short serum half-life of around 18 hours. That short half-life means that CRP levels quickly reflect the current inflammatory activity, making it a sensitive thermometer of acute changes.
Other APR proteins include fibrinogen, which is critical for wound healing, serum amyloid A, and ferritin and lactoferrin, which function as negative APR proteins by binding and sequestering iron, attempting to starve the invading bacteria of this essential nutrient.
This leads us directly to laboratory assessment and the interpretation of these inflammation biomarkers, and CRP is typically the preferred marker because of its sensitivity and rapid change.
However, here is the essential clinical caveat for you, the learner. Certain systemic autoimmune diseases like systemic lupus erythematosus, or SLE, systemic sclerosis, and even some malignancies like leukemia may have very active inflammation with only mild or minor CRP elevation. The key clinical insight is that if a patient with established SLE suddenly presents with a significantly high CRP, say above 100, the practitioner must immediately suspect intercurrent infection, rather than just a flare of their underlying autoimmune disease.
And the other major marker is the erythrocyte sedimentation rate, or ESR, often called the sludge test. It's an indirect, non-specific measure of how fast red blood cells fall through a plasma column in 1 hour.
And the mechanism is what you really need to understand. Normally, red cells repel each other due to negative surface charges. When the concentration of large, positively charged plasma proteins, primarily fibrinogen but also immunoglobulins, rises, they neutralize this negative charge. This allows red cells to stack up like coins, forming clumps called rouleaux.
And since these rouleaux have a far higher mass-to-surface area ratio than single red cells, they sediment much faster. So a high ESR means high plasma protein concentration.
Exactly, and the anchor here is that ESR is highly susceptible to non-acute factors. While acute inflammation raises fibrinogen, chronic conditions like multiple myeloma or SLE raise immunoglobulins dramatically, causing a high ESR even when the acute trigger and the CRP is low.
And conversely, abnormal red cell shapes, like sickle cells, disrupt rouleau formation, causing a falsely low ESR.
Very important distinction.
Now, when this beautiful, complex system malfunctions on a massive scale, we get septic shock. This is an overwhelming, uncontrolled systemic inflammatory response, often triggered by a massive release of LPS or endotoxin from gram-negative bacteria, which hyperactivates macrophages.
And the clinical picture is catastrophic. The macrophages flood the system with vast, uncontrolled quantities of pro-inflammatory cytokines, TNF-alpha, IL-1, causing massive, widespread vasodilatation and capillary leak. This leaves a profound hypotension, tissue edema, disruption of the vascular endothelium leading to widespread clotting, or DIC, and rapid multi-organ failure.
It's the immune system hitting the nuclear launch button for a localized threat.
That's a very good way of putting it.
And finally, chronic inflammation occurs when the inflammatory stimulus persists. Maybe a non-cleared microorganism or an insoluble foreign body. The system fails to resolve, leading to the ongoing accumulation of monocytes, macrophages, and T cells.
And a signature outcome of chronic inflammation is the formation of a granuloma. This is a highly organized, localized structure where macrophages, which turn into epithelioid cells and surrounding T cells, wall off an agent that the phagocytes cannot fully kill or digest. This is characteristic of persistent infections like tuberculosis, leprosy, and some fungal diseases where the pathogen is just too resilient to be cleared immediately.
Okay, let's perform our third check-in question. A patient with long-standing rheumatoid arthritis has a recent laboratory report showing a significantly elevated ESR, but their CRP is only mildly elevated and hasn't changed in months. Based on the ESR mechanism, what non-acute phase reactant protein is the most likely driver of that discrepancy?
The most likely driver is chronic hypergammaglobulinemia, meaning elevated levels of immunoglobulins. These positively charged, high molecular weight proteins neutralize the charge on red cells, promoting rouleau formation and raising the ESR, even though they are not acute phase reactants and thus do not affect the CRP reading. This is a classic board examination distinction.
All right, moving into part 4. When defenses fail, or immune deficiency.
When defenses fail, either due to a genetic defect, a primary immune deficiency, or an acquired condition, a secondary immune deficiency, the consequences are severe. Recurrent, severe, or unusual infections, often paradoxical autoimmunity, and an increased risk of malignancy.
And the most crucial conceptual anchor for PIDs is the infection pattern anchor. If you can categorize the type of defect, you can predict the type of organism the patient will succumb to.
That's right. Deficiencies in the immediate responders, phagocytes or antibodies, typically result in recurrent infections with encapsulated bacteria like S. pneumonia and H. influenza and fungi.
However, because T cells are the central regulatory axis, a defect here means a loss of coordination across both arms of immunity. Therefore, T cell deficiency results in infections from the widest variety of pathogens, viruses, fungi like pneumocystis, and protozoa. A T cell defect is the most profound kind of immune failure.
It's important to remember that secondary immune deficiencies are vastly more common clinically. Causes include aging, what we call immune senescence, leading to a 20-fold increase in infection susceptibility due to declining T cell function and poor vaccine response. Also, infection itself, like HIV or measles, and necessary medical interventions like chemotherapy, cytotoxic drugs, and therapeutic immunosuppression.
Diving into the specific primary phagocyte deficiencies. These are defects in the killing or migration process, leading to severe bacterial and fungal infections, often at unusual sites, and requiring aggressive, prompt treatment.
Chronic granulomatous disease, or CGD, is the textbook example. It is caused by genetic defects in the components of NADPH oxidase, leading to a functional inability to perform the respiratory burst. They cannot produce those toxic reactive oxygen species.
And the specific clinical consequence is susceptibility to catalase-positive organisms like Staphylococcus aureus or Aspergillus. Why is that?
Well, the reason, and this is the deep insight, phagocytes without NADPH oxidase can still produce small amounts of hydrogen peroxide via other pathways. Catalase-negative bacteria are sensitive to even these trace amounts. However, catalase-positive organisms produce the enzyme catalase, which breaks down the host's hydrogen peroxide, leaving the defective phagocyte totally defenseless.
And the result is chronic infection leading to that hallmark granuloma formation.
Precisely.
Another fascinating disorder is leukocyte adhesion deficiencies, or LAD.
These are defects in the adhesion molecules, typically the integrin beta-2 chain, which prevents the neutrophil from sticking to the endothelial wall.
And if the neutrophils can't adhere, they can't exit the blood vessel to reach the site of infection. Clinically, this presents with recurrent infections that crucially lack pus formation.
Yes. The neutrophils are present, but they are trapped in the circulation, leading to a paradoxical but characteristic finding of a very high neutrophil count in the peripheral blood.
Okay, looking at complement pathway deficiencies. Deficiencies in the terminal components C5, C9 lead to a failure of FMEC formation,
Resulting in the life-threatening recurrent infection by Neisseria species. The MNE is just indispensable for these encapsulated organisms.
But conversely, deficiencies in the early classical pathway components C2, C4 surprisingly lead to an increased risk of autoimmune disease, particularly SLE.
The theory is that the classical pathway normally aids in clearing circulating immune complexes and apoptotic debris, and the inability to do so allows these complexes to accumulate, which then triggers autoimmunity.
And management here is preventative.
Yes, patients require prophylactic meningococcal and pneumococcal vaccines, and often lifelong prophylactic penicillin to mitigate the risk of Neisseria infection.
Moving to primary antibody deficiencies, defects in B-cell function, these are generally the most common PIDs. They result in recurrent sinopulmonary and GI bacterial infections, particularly with those encapsulated bacteria that depend on antibody opsonization for clearance.
The most common PID is selective IgA deficiency, around 1 in 600. It often results in mild or asymptomatic infections, though some patients suffer from recurrent respiratory infections. And importantly, you cannot replace IgA via IVG, as IVG only contains IgG.
A more severe one is X-linked agammaglobulinemia, or XLA. It's caused by a mutation in the BTK gene required for B-cell maturation.
Affected boys present in infancy with severe recurrent infections. Their blood tests show a profound lack of B cells in the peripheral circulation and almost no circulating immunoglobulins.
Then there's a difficult heterogeneous condition, common variable immune deficiency, CVID, which often manifests in adulthood.
It is characterized by low serum IgG and a failure to mount effective antibody responses to new antigens. CVID is a difficult diagnosis because it is often associated with non-infectious complications, chronic lung damage or bronchiectasis, GI issues, and, paradoxically, autoimmunity like ITP.
The cornerstone of management for significant antibody deficiencies like XLA and CVID is immunoglobulin replacement therapy.
Yes, this involves periodic infusion of IgG harvested from thousands of healthy donors, either IVI or SEI. The goal is to provide passive immunity and maintain serum trough IgG levels within the protective range to prevent end organ damage.
And we must reiterate the general rule: live vaccines must be strictly avoided in all PIDs.
Absolutely critical.
Finally, the most catastrophic defects are the primary T lymphocyte deficiencies.
As we established, T cells are the conductors of the immune orchestra, so their failure causes vulnerability to nearly every type of pathogen.
Take DiGeorge syndrome, caused by a 22q11 dilution, which leads to variable failure of thymic development.
Right. The result is a heterogeneous spectrum of T-cell deficiency, ranging from mild to severe, often alongside other developmental defects like congenital heart disease.
And the most severe failure is severe combined immune deficiency, or SCID, where T-cell maturation is blocked entirely.
A classic form is X-linked SCID, caused by a defect in the IL-2RG gene, a shared component of several cytokine receptors. Without these receptors, T cells and NK cells simply cannot develop or function.
And SCID babies typically succumb to life-threatening viral, fungal, and protozoal infections within the first year of life unless successfully treated.
Treatment often requires the drastic step of stem cell transplantation to restore functional T cell and B cell lineages.
Okay, let's have our final anchor check-in for this section. We discussed chronic granulomatous disease, CGD, and the importance of NADPH oxidase. What is the precise metabolic reason that the defect in NADPH oxidase specifically makes CGD patients susceptible to catalase-positive organisms?
The answer lies in hydrogen peroxide. NADPH oxidase normally creates massive amounts of hydrogen peroxide for killing. If it's defective, the phagocyte relies on trace amounts of hydrogen peroxide made elsewhere. Catalase-positive organisms carry the enzyme to break down those trace amounts of H2O2, leaving the phagocyte with zero oxidative capacity against that specific invader.
Perfect. Now, part 5. When defenses misbehave, dysregulation and hyperresponsiveness.
Sometimes the immune system isn't underactive, but catastrophically overactive, particularly in terms of inflammation. This brings us to the fascinating area of the periodic fever syndromes, or PFS, which are genetic disorders of innate inflammatory regulation, essentially characterized by uncontrolled IL-1 production.
The most common is familial Mediterranean fever, FMF, prevalent in populations around the Mediterranean. It's caused by mutations in the MEFE gene, which affects the protein pyrin, a key component regulating the inflammasome we discussed earlier.
FMF presents with recurrent self-limiting episodes of high fever and serositis inflammation of the linings of the peritoneum, pleura, or joints. And during an attack, CRP levels skyrocket.
The major devastating complication, and the reason treatment is mandatory even if the attacks are tolerable, is the development of reactive AA amyloidosis.
Untreated chronic inflammatory surges, especially in FMF or chronic rheumatoid arthritis, lead to the sustained production of serum amyloid A, or SAA. SAA is then misfolded and deposited in critical organs.
Which leads us to amyloidosis as a diagnostic concept, the extracellular deposition of insoluble fibril proteins in tissues, leading to organ dysfunction.
And the gold standard for diagnosis is a biopsy stained with Congo red dye, which exhibits a highly distinctive apple-green birefringence when viewed under polarized light.
For FMF, treatment is remarkably simple and effective. Lifelong daily colchicine.
Which blocks microtubule assembly and disrupts neutrophil function, dramatically reducing the frequency of febrile attacks and almost completely preventing AA amyloidosis. For refractory cases, anti-IL-1 inhibitors may be used.
Now, when the adaptive system turns on itself, we enter the world of autoimmune disease, the failure of immune tolerance.
The etiology is complex, involving genetic predisposition, so strong HLA associations, and environmental triggers.
One powerful environmental trigger is molecular mimicry.
This happens when an antigenic determinant on a pathogen is structurally so similar to a host protein that the immune response mounted against the invader mistakenly cross-reacts and attacks the self-tissue. A classic example is Guillain-Barré syndrome, an autoimmune neuropathy often triggered after a Campylobacter jejuni infection.
To classify the mechanisms of immune-mediated tissue damage, we use the universally critical Gell and Coombs hypersensitivity classification.
Okay, so type I is immediate hypersensitivity, or allergy, IgE-mediated, which we'll detail in a moment. Type 2, or cytotoxic antibody, involves IgG or IgM antibodies binding to fixed antigens located on the surface of specific cells or tissues. This binding triggers destruction via complement activation or phagocytosis.
So autoimmune hemolytic anemia, for example.
Exactly. Or hyperacute rejection in transplantation.
Type 3 is immune complex.
Right. This involves IgG or IgM binding to soluble antigens, forming intermediate-sized circulating immune complexes. These complexes deposit passively in areas of turbulent flow, such as small blood vessels in the kidneys, joints, or skin. Deposition activates the classical complement pathway, causing massive inflammation and tissue damage.
And this is the primary mechanism underpinning diseases like SLE, particularly lupus nephritis.
And cryoglobulinemia as well. The location of the complex deposition dictates the specific pathology.
And finally, type IV, or delayed T cell.
This one is unique because it is purely cell-mediated, involving activated T cells and macrophages, causing direct tissue damage, with no antibody involvement necessary. It's delayed because it takes 24 to 72 hours to manifest clinically, as T cells must migrate and activate.
Clinical examples would be the tuberculin skin test, contact dermatitis, type 1 diabetes, Hashimoto's thyroiditis, and acute cellular transplant rejection. This classification system is foundational.
Absolutely foundational.
Focusing on type IHSR, or allergy. ATP is the genetic predisposition to produce an exaggerated IgE response to otherwise harmless environmental allergens.
The mechanism is a two-step sensitization process. Initial exposure to the allergen results in B cells, with Th2 cell help, producing large amounts of specific IgE. This IgE then circulates and binds strongly to high-affinity receptors on the surface of mast cells and basophils, effectively priming them.
And re-exposure to the exact same allergen causes the antigen to cross-link multiple adjacent IgE molecules on the mast cell surface. This mechanical signal is the trigger for rapid degranulation, releasing preformed mediators like histamine, prostaglandins, and leukotrienes, resulting in the classic early phase response symptoms: urticaria, bronchospasm, rhinorrhea.
Diagnosis utilizes two major approaches. Skin prick tests are fast, where a local wheal and flare reaction is assessed 15 minutes after puncture. The caveat for you, the learner: antihistamines must be stopped several days prior, as they will inhibit the histamine response and cause a false negative.
And if skin testing is inappropriate, we use specific IgE tests, or RAS, to quantify serum IgE antibodies against specific allergens.
A more advanced tool is component resolved diagnostics, or CRD. This uses purified individual allergenic molecules to detect IgE. CRD is valuable for high-risk allergies like peanut because it allows clinicians to distinguish between genuine sensitization to dangerous storage proteins and mere cross-reactivity to benign-related proteins, dramatically improving risk stratification.
Finally, we must differentiate types of angioedema: that episodic, localized, non-pitting swelling, often involving the lips, tongue, or larynx.
Right. Allergic or idiopathic angioedema is common and is mediated by histamine release from mast cells. It is nearly always associated with urticaria or hives, and most importantly, it responds rapidly to standard treatment, antihistamines and glucocorticoids,
The critical distinction is hereditary angioedema, or HAE.
which is caused by a deficiency or dysfunction of C1 inhibitor. C1 inhibitor normally regulates both the classical complement pathway and the kinin cascade. Deficiency leads to uncontrolled activation of the kinin cascade, resulting in massive local overproduction of bradykinin.
And this is the critical clinical difference. HAE attacks are mediated by bradykinin, meaning they are not associated with urticaria and are completely unresponsive to antihistamines or steroids.
And HAE, especially when affecting the larynx, is life-threatening and requires specific treatments like C1 inhibitor concentrate or bradykinin receptor antagonists.
Okay, let's run a rapid-fire HSR check to make sure the mechanisms are locked in. Which type of hypersensitivity reaction is responsible for acute cellular transplant rejection, and which type is responsible for the joint inflammation seen in serum sickness?
Acute cellular rejection is T-cell mediated and is a type 5V HSR. Joint inflammation in serum sickness is caused by circulating immune complex deposition, making it a type 3 HSR.
Perfect. On to our final section, part 6, New Frontiers, Transplantation, and Tumor Immunology.
We finish with the modern frontiers, beginning with transplantation. The immune challenge here is driven by genetic disparity, specifically the inevitable mismatch of HLA molecules between the recipient and the donor organ.
So the recipient's immune system, particularly the T cells, recognizes the donor HLA molecules as foreign and mounts an aggressive attack. And we classify the rejection process into 3 stages.
Right. Hyperacute rejection occurs minutes to hours after the blood supply is restored to the graft. It's a rapid type 2 HSR, mediated by recipient antibodies that were preformed and which bind immediately to the donor HLA antigens, leading to rapid clotting and graft destruction. This is now rare due to mandatory pre-transplant cross-matching.
The most common rejection is acute cellular rejection, typically occurring in the first month.
And this is the classic type IV HSR, mediated by newly activated T lymphocytes recognizing the donor's foreign HLA. It usually causes a drop in graft function, but is often treatable with a temporary boost in immunosuppressive medication.
And chronic allograft failure is the major long-term cause of graft loss, occurring months to years after transplant. It involves a mix of immunological damage and non-immune factors, leading to insidious vascular fibrosis and scarring within the organ.
Managing transplantation requires precise, lifelong immunosuppression, using multiple synergistic drugs to block T-cell activation and proliferation at different points. Key agents include calcineurin inhibitors like tacrolimus, which block IL-2 production by inhibiting the calcineurin enzyme, thus shutting down T-cell proliferation.
And the primary long-term side effects of this necessary immunosuppression are infections, like opportunistic pathogens and, crucially, malignancy.
Yes, by suppressing T-cell surveillance, we lose control over oncogenic viral infections. T-cell suppression is directly linked to an increased incidence of EBV-associated lymphomas, HHV-8-associated Kaposi sarcoma, and HPV-driven skin tumors.
This brings us neatly to tumor immunology. The concept of immune surveillance posits that the immune system is constantly checking for and eliminating damaged or mutated cells before they become tumors.
Tumors, however, are masters of evasion. They use many strategies to hide, such as downregulating the very HLA molecules that T-cells need to recognize them, or, more cunningly, co-opting the body's natural inhibitory pathways, the immune checkpoints.
And this profound clinical insight led to the development of immune checkpoint blockade, or ICB. By developing antibodies that block these natural inhibitory molecules like anti-CTLA-4 or anti-PD-1, we are essentially cutting the brakes on the T cell, unleashing a massive, targeted anti-tumor immune response against cancers like melanoma and certain lung cancers.
And the clinical drawback perfectly reinforces the concept of peripheral tolerance. By removing those inhibitory brakes, we introduce serious, drug-induced, immune-related adverse events, essentially autoimmunity. Clinically, this manifests as colitis, hepatitis, pneumonitis, or endocrinopathies, requiring careful management with high-dose steroids to restore balance.
And finally, the ultimate precision tool, CAR-T cell therapy. This involves taking a patient's own T cells, genetically engineering them ex vivo to express a chimeric antigen receptor, or CRR, that specifically recognizes their cancer, expanding those cells in a lab and then infusing them back.
This is immensely powerful, particularly in refractory hematological malignancies. But the power brings immense risk, notably the cytokine release syndrome, or CRS. This is an uncontrolled systemic activation of immune cells, leading to severe systemic inflammation, essentially a controlled induced septic shock, along with the long-term complication of subsequent B-cell and antibody deficiency.
Wow. We've completed our deep dive, a complex journey starting with the physical walls and immediate security guards of the innate system, then moving to the exquisite specificity and memory of the adaptive special forces. And we finish by tracing what happens when that balance is disrupted, leading to deficiency, dysregulation, rejection, and the challenges of fighting cancer.
The central narrative of immunology is just constant vigilance and balance. So to summarize our key conceptual anchors for you, the learner. First, adaptive hallmarks are non-negotiable. Specificity, adaptivity, and memory. These are the foundation for vaccine success. Second, the infection pattern anchor is critical for clinical reasoning. Phagocyte or antibody deficiencies mean vulnerability to encapsulated bacteria and fungi. T-cell defects mean susceptibility to all pathogens, especially viruses, protozoa, and fungi.
Third, inflammation markers, particularly the CRP-ESR discrepancy, must be interpreted cautiously. High ESR with low CRP usually points to chronic inflammation driven by non-acute phase reactants, specifically immunoglobulins.
And fourth, modern therapies demonstrate the system's fine control, modulating specific cytokines like IL-1 and TNF-alpha in autoimmunity, or removing specific brakes like PD-1 and CTLA-4 to empower T cells against cancer.
It's just astonishing how often the entire system's failure or success boils down to the presence or absence of a single regulatory protein.
Indeed. We've anchored this entire deep dive on the concept of specific proteins, a single defect causing SCID, or a single missing anchor causing PNH. And we've seen therapeutic triumphs where we simply block a single molecule like PD-1 or C5. So given the therapeutic successes of immune checkpoint blockers in cancer, which essentially remove a natural brake on the T cell, what complex societal and therapeutic challenges might arise when we achieve the ability to use gene editing to permanently and precisely fine-tune the human inflammatory set point, perhaps removing a mild inflammatory tendency forever? It's a profound question of control and consequence to consider as you move from the textbooks to the bedside.